and then opening it up for discussion. And you guys could ask questions through the chat, or you could just raise your hand, and we could do it that way. But I think, to me, it might be more interesting if I'm not just sitting here talking for an hour at you guys when I don't really know, what your interests are, what your questions might be. So that's what I was hoping to do. So let's try that and see how it goes. And if you guys are really quiet and you don't have questions, then I can always just keep talking or fill in. So my path to medicine, and I'll also say that I didn't really prepare this very carefully. So this is going to be off the cuff. I don't have any slides or anything like that. So my path to medicine, I grew up in northern New Jersey, and my father's actually a physician. There's a lot of physicians in my family. So my father's a physician, he's a dermatologist, and actually both of his parents, so my paternal grandparents were both physicians. One was a thoracic surgeon, my grandfather, and my grandmother was also a dermatologist. And then, believe it or not, my grandmother's father was also like a kind of old school family physician. This is my great grandfather in New Jersey. So I came from this long kind of tradition of physicians, and there's almost like a pressure to become a physician. I think when I was in sort of middle school to earlier high school, I didn't want to be a physician. I wanted to be something else, to be a little bit different from my family. But then later in high school and then in college, I did get interested in medicine. And so in college, I took the pre-med courses. I went into it thinking in college that I just probably wanted to be like an internal medicine doctor or general doctor. Applied to medical school, got in. So I went to Harvard College and Harvard Medical School. So when I was in medical school, I got actually really interested in the neuroscience course in the second year of medical school. So like the neuroscience and genetics courses got me really excited. And I, when you go to medical school, people often want to know what specialty you're going to go into. Like as soon as you say you're interested in medicine, people are like, what specialty? Before you've even started medical school. So what I was thinking was, if you choose a specialty, what you end up doing is you spend basically a lot of your career thinking about like one organ system usually, or maybe one category of disease processes. And I thought, well, what's the most interesting organ? The kidney is really interesting, and different organs are interesting, but to me, by far the most interesting organ was the brain, and like brain functioning, and sort of mind-body problem, and how does the mind and thoughts and emotions come out of the brain? I mean, it's just like endlessly fascinating and mysterious. So when I was in medical school, I thought I want to do something brain related, and like, what are the brain related specialties? Well, there's psychiatry, neurology, child psychiatry, child neurology, neurosurgery, anesthesiology, in a sense, is brain related. So I thought of all those. I mean, ultimately, it came down to me between psychiatry and neurology. And I thought that psychiatry was just the more interesting aspect of brain functioning, because you're getting at sort of like higher order thought and emotion and things like that. Whereas a lot of neurology is peripheral nervous system, like peripheral nerves, neuromuscular junction, things like that, which are really important, but they weren't as interesting to me. So ultimately, I ended up being interested in psychiatry. But in the middle of medical school, I got so interested in the brain and neuroscience, I thought, should I try to switch into an MD PhD program? Like I was in a straight MD program. And I talked to a bunch of people. I talked to some PhDs who were in neuroscience and some MDs who did neuroscience. And basically the message I got was just, their advice was finish medical school, do a residency program. And then if you're still interested in science, do a postdoctoral fellowship in science. So that's what I ended up doing. I wouldn't necessarily recommend that for those of you who think you're really interested in basic science. It may be better from the outset to apply to an MD PhD program, but partly because you get free tuition when you apply to it when you're in an MD PhD program. But anyway, that's what I did. So I went through medical school. I did my psychiatry residency at Yale, and then I did a postdoc in neuroscience at Yale in someone named Eric Nestler's lab, who, and I should also say during my psychiatry residency, I started to get really interested in the autism spectrum, because right at the beginning of my psychiatry residency, I had an experience working in a, what was called the Clinical Neuroscience Research Unit at Yale. And they had a program for adults on the autism spectrum, which was kind of unusual. And I started working with some of the patients, and I just found them really, really interesting. Some of them were quite intellectually bright, but they just had difficulty understanding relationships and interactions and understanding other people's points of view. And I thought that was really interesting. And I also felt a lot of sympathy for them. One patient in particular that I worked with, a man like in his mid 30s. And I just felt like, what is that makes that so difficult for him to understand relationships and interactions, and something that most of us take for granted, I think. So I wanted to understand it better. And I also really felt for him, and then felt this desire to help. So then I started doing some clinical research with someone named Chris McDougall, who is the person who is heading this adult autism spectrum program. And that's really remained an interest for me. I mean, as Larissa mentioned, I'm now I'm the founder and director of the adult autism spectrum program at Penn Medicine. So that's remained a really sustained interest for me. But when I did that first postdoc after medical school, or after psychiatry residency, I did a basic neuroscience postdoc with Eric Nestler, and I was studying reward pathways and stress pathways in the brain, and the dopaminergic systems in the brain that sort of mediate reward and stress and motivated behaviors. Then I did a second postdoc in someone named Lee Silver's lab, who was doing genetics, and we studied genetic influences on social behaviors in mouse models. So we studied genetics of aggressive behaviors and other sort of social affiliative behaviors. And then after that postdoc, I got my job at University of Pennsylvania. So now we're in 2002, almost 20 years ago, when I started working at Penn. And then at Penn, my lab has focused on the neurobiology and genetics of autism and social behavior development. And my clinical work focuses on adults on the autism spectrum. So I have a outpatient consultation program where I do diagnostic consultations and treatment consultations. And then I also have sort of like a small practice where I see some patients in an ongoing way. But I would say about 80% of my time is in research. For years, I was really focused on mouse models, but now I've transitioned more to studying humans, and especially the human genetics of autism, as well as trying to develop and test better treatments for adults on the autism spectrum to help them with social functioning. So that's what I focus on now. In terms of a day in the life of myself, I do a variety of things. It really depends on what day of the week. Like Mondays is my heavy clinical day. So pretty much all day long on Mondays, I'm seeing patients and doing diagnostic consults. I can say more about what that involves, but treatment consults, seeing some patients for ongoing treatment. And then scattered through the rest of the week, there's a couple of other patients that I see, but mostly the rest of the week I'm doing research in human genetics of autism and treatment studies. So a typical day in the life of that involves a variety of things. One is applying for grant funding to support the research. Earlier on in my career, it was actually hands-on research, like in the lab, pipetting and things like that. Now it's more like administering a research lab. So I have students, I have actually college students, Penn college students working in the lab. I have a neuroscience graduate student. I have a postdoctoral fellow who are all working on either on this genetics project or treatment project. And so, some of my daily life involves meeting with them, supervising them, writing writing with them research papers to report our results, editing papers that they've drafted, things like that, having meetings with other investigators that I collaborate with, an endless stream of email. So it's like the kind of usual things you might guess. And then in terms of a sense of like the types of cases that I see, a common case I will see will be a man or woman in their, let's say, 20s or 30s. But sometimes I will see people as young as like 16 years old, or I think the oldest person I've seen for a diagnostic consult for autism was in his 70s or 80s. But I would say the average age that I'll see is like someone in their 20s or 30s, maybe 40s, who for years has struggled in certain ways, like often with making friends, with relationships, with things like that, and who may have other symptoms that they might have read about the autism spectrum on the web or something, or read some books about it and started to wonder, like, I wonder if this is what's going on with me. And many of them have gotten other diagnoses along the way, like maybe an anxiety disorder or ADHD, attention deficit hyperactivity disorder, or depression. And they may feel like those issues are real, but they often feel like, but those diagnoses don't fully capture all of the issues that I've been grappling with for my life. So I really want to sort of get checked out and get a evaluation to see if I might be on the autism spectrum. So what I do with them is they fill out certain kind of standard assessment questionnaires, and then I do a really detailed clinical history and developmental history with them. It usually involves me sitting down with them for like 2 to 3 hours and going in a lot of detail in terms of their history. If they have old records, like from other doctors they've seen or psychological evaluations, I'll also go through them. And then I will write up a report. It's usually a pretty long, like a 10 to 15 page report summarizing all this, send it to them, and have a follow-up appointment with them, and basically give them my opinion about what their diagnosis is. What's been interesting to me in doing this is that, you might think that giving someone a diagnosis of being on the autism spectrum might be upsetting in some way, because it's, it's a fairly significant diagnosis. But what I found almost universally, I mean, maybe there's some exceptions to this, but I would say the vast majority of people who I've given this diagnosis to feel actually tremendously relieved, and they feel like it's almost like it's really changed their life. It's really quite amazing. And because I think what happens is they've been struggling with some issues for years, and it's just gone undiagnosed, and they feel like finally they can sort of like have some greater sense of what's going on and what might be able to help them. And it's not just that they're crazy or they're a bad person, or, people often have these feelings like this. Maybe I'm just like, there's something wrong with me and no one else has this, but to also know that they're not the only one, that there's a lot of people out there who have these same kinds of issues. And in fact, there's like a community of people more and more who are online that they can connect with, and so on. So it's actually been really gratifying to do these consults. I feel like it's really, it's become sort of routine for me in a way, like I do many of them, but I feel like for the patients, it can be a really very, almost like a profound experience for them. And then I also primarily work in therapy, like do psychotherapy with a small group of patients who we're working on sort of social understanding, social skills, stress management, things like that. So I think I've covered briefly a lot of the main points, like my path, a day in the life, and generally the kind of clinical work or the kind of cases I see. But I mean, I'm happy to go into any more detail on any of these things, or just even, answer general questions about a path towards medicine, or I've also worked in neuroscience. So I've worked a lot with PhDs and, yeah, some of my closest colleagues are basic science PhDs. So for any of you, considering either med school or grad school or MD, PhD, or, anything related to this, I'm happy to take questions or have a discussion.
Yeah, so I think we have some questions in the chat right now.
So I could open the chat if that's the easiest way to do it.
Yeah, perfect.
Okay. All right, so I'm going to the top here. So Avi asks, do you prefer the more administrative aspect of your research or the more hands-on aspect you had before? Really good question. I think I like them both in different ways. The hands-on science in the lab, when I was doing more basic research, there was a kind of satisfaction to it in a way. You're working with your hands, you're doing experiments, you're actually, extracting DNA, you're seeing DNA, you're running down a gel. When things work really well, it can be really kind of fun and cool. It also, though, takes a lot of frustration tolerance, because typical of work in the lab is like things don't work, and then you have to do troubleshooting, and it can be frustrating. And sometimes, depending on the kind of experiments you're doing that are hands-on, it can be like, really a lot of your day is taken up with this experiment, and it can be a little bit exhausting. And I'm someone who also enjoys writing. So in some ways, being in a more administrative role involves more of the writing, like writing grants, writing papers, things like that. And I do enjoy working with students and postdocs and things. So that part of it is fun for me. So, I think they each have their pluses and minuses. So Shannon asks, have you found that a certain sex is more likely to be undiagnosed until adulthood? That's a great question. I don't have a really completely scientific answer to that, but I would say my guess is that it actually may be more women who are undiagnosed until adulthood than men. I think, the kind of standard knowledge about the autism spectrum is that it's more common in males than females. So it's something on the order of 4 to 5 males for every 1 female. And I think it tends to be under-recognized in girls and women because it presents a little bit differently. Girls and women on the spectrum tend to be to appear more socially skilled, I would say, than men. And so they may not present like someone classically on the autism spectrum. And there's been a lot written about camouflaging and masking, like that women or girls find a way to kind of pass as quote unquote normal. So if I had to choose one, my guess is that it might be women who tend to be undiagnosed. And I do see a lot of women in my practice who come for evaluations. And then Jackson wrote, building on the first question, as an MD and PhD, do you feel like you have less time to do the things you really enjoy since you effectively have 2 careers in one? I.e., do you feel like lab work takes away from clinical work or vice versa? Another really good question. So first of all, I should say I don't have a PhD, I have an MD, but I did postdoctoral work. But I think the gist of the question though is like, as someone who does both basic science research or research and clinical work, do I have less time to do the things I enjoy? I think it's evolved over time. And one sort of big message I would give to you guys is that I feel like when you're in high school or college, you might feel like you really need to make a decision now that's going to be almost like a final decision for your life. Like I'm going to choose this pathway or that pathway, and that's going to be it for the rest of my career. And to some extent, that's true. I mean, the choices you make now do have an impact on your trajectory for sure. But on the other hand, you can evolve and change over time. And I feel like over the course of my career, the amount of time I've spent doing various things has changed, and my own direction has changed gradually over time with my interests. So, early on in medical school and residency, I was doing exclusively clinical work, right? So or, the early coursework of medical school, but then lots and lots and lots of clinical work. So I would say for, let's say, 7 years, 5 to 7 years, let's say, I was doing a ton of clinical work, including an internship in pediatrics before my psychiatry residency, where I was up all night in the hospital doing clinical work, on call every second or third night. So a huge amount of clinical work. So, and I really enjoyed it, but in some ways then going into the lab was kind of like a nice change of pace, where now I could just focus on doing my experiments, and I wasn't on call all night long and things like that. So I really enjoyed that. But now where I am now, I would say in my early years at Penn, I spent a lot more time on the research lab, and then I did kind of miss clinical work. And so then I started to build up this adult autism spectrum program. And then I would say over the course of these almost 20 years at Penn, I think I've gotten less, I don't want to say I'm less interested, but I feel like my passion lies a little bit less with the basic research and the mouse models now, and more with humans and really trying to bring help to humans. And so over time, I've shifted more towards doing direct work with human beings. And so I feel like I've been able to strike a pretty good balance. Okay, so then let's go to Melody's question. How do you communicate diagnoses to your patients? How do you help patients who might not receive the news of their diagnosis in a positive manner? That's a really good question. Well, one thing I would say, it's not quite like it would be, telling a patient that who thought they were perfectly healthy that suddenly like they have cancer, or some really serious illness. It doesn't tend to feel like that, because what happens is that in most of these cases, people have already suspected it about themselves, and in many cases, they've been wondering like for years, or at least for months, whether they might be on the spectrum. So it doesn't tend to come as a huge shock to them. And but in terms of communicating it in a positive way, one thing I say is that, and also I should say, like the autism spectrum is a really wide spectrum, right? And there are some people on the autism spectrum who are more severely affected, who have intellectual disability, who may be, not communicate in a kind of typical way, be nonverbal. Those cases are almost never missed in childhood. I mean, occasionally I do see some cases that are missed, but it's pretty rare. So usually the cases that I'm seeing in adulthood have more, let's say, that are more mildly affected, have somewhat more subtle symptoms. And so what I talk to the patients about is the idea of neurodiversity, and the idea that, and some of you may be familiar with this idea, but the idea that there's diversity among people and among humans, and there's diversity of cognitive profiles, like the idea that there are, each of us has strengths, some things that come more easily to us and some things that are more difficult for us. And you can think of the autism spectrum as a particular kind of neurodiversity, a particular pattern of things that come more or less easily to people. And so for people on the autism spectrum, like social cognition, like understanding other people, understanding relationships, navigating conversations, that's often more challenging for them. And they also may have sensory sensitivities and things like that. So it's a particular constellation. So rather than thinking of it in a really stigmatizing way, as like autism is a disease and you have this terrible disorder, I don't present it that way. I present it more as like the idea of neurodiversity, but not to minimize though the challenges that they faced from this. I mean, sometimes it's had a huge impact on their lives, but I think when you put it in that context, it can feel less dire, less stigmatizing. And also that just because they're on the autism spectrum doesn't mean that they can't learn and grow and develop in some ways. Like, even though some of these things may come less easily to them, they're still capable of learning and developing, growing the skills that they do have. So I think presenting it that way seems to be helpful. So then forgive me if I pronounce the name wrong, but Eileen asks, similarly, do you think your career might have been different if you had only gotten your MD and not pursued a PhD? So like I said before, I don't actually have a PhD. I have an MD, but then did these postdocs to get into basic research. I mean, I think that if I hadn't done basic research and I had really just focused on clinical work and clinical research, then yeah, it would have been a different trajectory, for sure. I don't know if I'm fully answering Eileen's question there, if that was the intention. So if I'm not, feel free to speak up, Eileen. So Liam asks, do you continue meeting with and treating your patients after you provide them with a diagnosis? If not, where do you direct them for further support? Yeah, great question. So so a subset of the patients that I see, I do continue to see for treatment, but I would say the majority of patients I see, I refer elsewhere. And it really depends on, what their needs are. So if their need is for well, actually what I do in the report is I provide a whole series of resources and referrals for them, depending on their particular needs. Like sometimes I'll refer people to a psychiatrist for medication management. Sometimes I'll refer them to either a psychiatrist or psychologist or other therapist for therapy. Some are interested in being involved in like peer support groups. So there's some of them in the Philadelphia area that I'll refer to. Some, usually when people get a new diagnosis of being on the autism spectrum, they should at least be offered the possibility of a medical genetics evaluation. So I'll typically refer them to the medical geneticist here at Hospital of the University of Pennsylvania. So yes, I will provide a whole set of resources for them. So then Denise writes, did you always know that you were interested in lab work compared to clinical work? No, I mean, I went into medicine, like in college, I thought I was clearly interested, much more interested in clinical work. And in some ways, I felt like I was sort of dreading in some ways the pre-med courses, like organic chemistry and all these things. But strangely, this may say something about me, but in some ways I did not love inorganic chemistry in college, but I found organic chemistry actually more interesting than I thought it would be, especially the second semester of organic chemistry and sort of biochemistry, when you started to learn about things really related to life and, like what are vitamins and how do they work chemically in the body and things like that. I started to find it interesting. So I think I started out with an interest in clinical work, but then I had kind of a growing interest in science. In college, I was I should have said I was a history of science major. So I was not like a chemistry major or something like that. I was not a basic science major. So I've had an interesting path, I guess, because I started out not being quite as interested in the hard sciences, but then got into neuroscience. So then Isabella asks, would you say that often your patients that have been diagnosed with other disorders like anxiety, ADHD, depression, etc., feel more reluctant to seek a diagnosis for symptoms that might not be explained by previous diagnoses? I don't know that they're more reluctant. I think that what happens, at least when they get to see me, is that they've gotten these other diagnoses. Either they feel like one or more of those diagnoses don't really fit well, or they may feel like, yeah, I think I do have ADHD, but I don't think that's the full explanation for what's going on with me. I feel like there's more than just that, and I know other people who have ADHD, but they're not grappling with the kind of social communication issues and relationship issues that I've been grappling with. So I don't know that they're really more reluctant. And I would say, one thing I should say is that in psychiatry, co-occurring issues are more the rule than the exception. So some people feel like, and sometimes patients come to me with this and they feel like, I want to find like the one explanation, like the one diagnosis that explains everything. And, sometimes that is true. And there is one diagnosis that kind of explains everything. But more often than not, there are a couple of things or, several things going on. So Aya asks, how did you get involved with doing psychotherapy with patients? Psychotherapy is part of psychiatry. So like when you go into psychiatry and you do a residency and you get trained as a psychiatrist, you learn, or you should learn ideally, both some psychotherapy and some biological approaches to treatment, including, largely psychopharmacology using medications, but there are other biological approaches as well, like transcranial magnetic stimulation and other biological approaches. But so, yeah, I mean, I think there's a whole history of psychiatry where the pendulum has swung between, more of an emphasis on psychotherapy versus biological. Like in the 1950s, most psychiatrists were mostly focused on doing therapy, and there weren't even that many medications available to treat patients. Then in as you got into 60s, 70s, 80s, there was this sort of resurgence of biological psychiatry. And, then Prozac came along, I think in the 80s, in the early 80s. And then people felt like, forget about psychotherapy, we can just do it all with medications. But I think then the pendulum has swung back and we realized there are some really effective psychotherapies. And so, they're both useful tools. Then Camille asks, you mentioned that when you chose your specialty, you had to decide between what type of neurological field you were interested in, like basic science of neuroscience versus the higher order thought and abstraction associated with psychiatry. What is your advice for students who are interested in the brain but are struggling to determine whether they are more interested in the basic science aspect or the applied sciences? Yeah, that's a good question. So some of you may be struggling with this, should I get an MD or should I get a PhD? Should I go into grad school for basic science? Or should I go into, let's say, like PhD in clinical psychology? So I would say that can be a hard decision sometimes. I mean, for some people, it's really clear. Like, I really want to be a doctor. I want to be a medical doctor and I want to see patients, or I never want to see a patient. And I'm really, really into basic science. So in those kind of situations, it's clear. There are some people though, who are kind of interested in both and they're on the fence about it. I guess my advice would be, if you think that you might want to see patients in any kind of clinical way, like take care of patients, then it is really useful to have a clinical degree, like an MD, or if you were more into like psychology, like even a PhD in clinical psychology, because then you're able to see patients. And with those degrees, with an MD or a PhD in clinical psychology, you can also do research. But if you know that you never want to do that kind of clinical care and you're really primarily interested in research, then graduate school might make sense, because why do clinical training when you don't want to see patients? I think, and this is a little bit of opinionated of me, but I think from a really practical life perspective and just making a living and things like that, there is some advantage to having a clinical degree, like an MD, or let's say an MD or a PhD in clinical psychology, because it gives you more options. You have more ways to make a living. As a basic scientist, there are a number of ways to make a living. Like, you could be a professor, and you're, either you're getting paid for your teaching or you're getting paid for research, but then you've got to constantly be applying for grants and grant funding, which can be challenging. Or you could work in industry doing basic research. I think if you have a clinical degree, there's a little bit of an advantage. You could do all those things that I mentioned, but you could also see patients. So it gives you more versatility, I would say, if you have a clinical degree. So I'd say there's some advantage there. Okay, so next question from Sean. How do you go about coming to the process of a specific diagnosis after you meet with the patients? Do you consult other clinical experts, consult past research info, et cetera? Yeah, so in my, first of all, in psychiatry, the way diagnoses are generally made is through behavioral symptoms. Like psychiatry is at a point where we don't really have many lab tests available. It's not like you can just get a blood test and tell if someone is on the autism spectrum, or get even a brain scan and tell if they're on the autism spectrum. It's really done by clinical history and developmental history. That's not necessarily a great thing. I mean, I think the field of psychiatry needs to get better, sort of more objective biological tests to add to its armamentarium, but that's how it is right now. So, and there's a book that some of you might have heard of called the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, that has criteria for psychiatric diagnosis, has diagnostic criteria. So basically what I'm doing is I'm going through the patient's clinical history and developmental history. With autism spectrum, it's an early onset developmental disorder. So it's not always diagnosed in childhood, but if someone knew what they were looking for and was looking carefully, in theory, it should be diagnosable by like age 3, 4, 5 years old. So whenever possible, I try to talk to people's parents if they're available, or they're, someone who knew them really well when they were a young child. So it could be like an older sibling or a parent or something like that. That kind of developmental history is really useful. And one of the assessments we use is a assessment of early development that a parent would generally fill out. Like I said, I do review their prior records, like if they've had neuropsychological testing. There are some cases where I feel like it's a diagnostic dilemma where I might consult with other clinical experts or have them evaluated by, a neurologist or a neuropsychologist or something like that to make sure we're not missing something. But in most cases, I can usually just do it on my own with this process that I described. So again, I may mispronounce this name. Savani asked, do you feel that your undergrad education prepared you to practice medicine? I don't think my undergraduate education alone prepared me to practice medicine, which I guess is kind of obvious. Like medical school and residency was really necessary. But I do feel like my undergraduate education was super helpful in many ways. Like the scientific education I got, even just the humanities and social sciences and the ability to write and do all those things, and sort of critical thinking, analytical thinking that I developed as a college student, I think was really, really helpful. Okay. Akshatha asks, what would you say is the most challenging part of your work, the clinical aspect or the hands-on research in the lab? Right now, I would say in some ways the most challenging aspect is the sort of continual process of raising funding for the lab. So the grant applications are really challenging, and you don't get them all, and you spend a lot of time and effort on writing up these grant applications, sometimes over the period of months, and then they don't get funded. Some of them do get funded, but you need a lot of like frustration tolerance. That's one thing you definitely learn, that not everything you do is going to work out and go well. And sometimes that can feel like wasted effort, but after you've done it enough, you realize like if one of them doesn't get funded, you put all the effort into that application, and then you can turn it into the next application that may get funded. So in some ways, I feel like that's some of the most challenging parts of what I do. Amy asks, what general advice and tips would you give to undergraduates that want to get into your field? Are there any actions you think we should be taking right now? I'm not sure if Amy means medicine in general, or psychiatry specifically, or neuroscience, but I think for undergraduates, I think try to get as many. First of all, my general advice is enjoy college. I think college is actually, even though it may not feel like it at times, like I think college is potentially like a really great time of your life when you get to take courses and explore different things and make friendships and, do all kinds of college things that can be a great part of life. But I think in terms of, getting into the field, I think doing what you're doing right now, going to sessions like this and getting as much experience as you can in terms of talking to people in the field, like talk to professionals who are in the field that, you might be interested in going into, and get a sense of like, what is their life like? What is their daily life like? Are they happy with their career? Like, what do they like about it? What do they not like about it? Try to get some exposure if you're interested in medicine, like volunteer in the hospital. I know that's sometimes easier said than done because lots of people, there's like a long waiting list to get into volunteer at HUP, I think, the last I heard. But try to get some clinical exposure and see if you like that environment and that seems exciting to you. If you're interested in science as a possible career path, then approach some professors and like work in the lab and get a sense of like, do you enjoy this? I think, one thing that's really important to get a sense of is like, what are you going to really like day to day in the long run in your career? And so getting those kinds of exposures, I think, helps you to get a sense of like, what excites you? Like, what do you think could keep you excited for the long run in your career? Janai says, I'm super interested in research, particularly clinical research with actual patients. You mentioned working with mice, and I was wondering, do you feel mouse models have been translatable to the human condition, or do you think research with mice has been beneficial? Do you wish you had started doing clinical research with patients earlier? Really, you guys ask excellent questions. I actually did start with clinical research. Like when I was in my residency, I started out by doing clinical research on adult autism with Chris McDougall. We were doing psychopharmacology trials and things like that, which I really liked. What at that time in my life, I felt like I really want to get, I don't want to just keep trying one drug after another. And, there's a little bit of benefit, but maybe not that much benefit. I wanted to get sort of deeper into understanding the neuroscience. And I thought that's the way the breakthroughs are going to really happen. And I still think that that's true in many ways. But I think for psychiatry in particular, modeling the behavioral aspects of psychiatric disorders in animals has been really challenging. And it's not always very easily translatable between animals and humans. And so over the course of my career, I have gotten more interested in directly working with humans and, making sure that what I'm doing is really relevant. I think both are valuable. I think basic research is really, really necessary and valuable. And I think clinical research is as well. So I would say, Janai, you're saying you're particularly interested in clinical research with patients. And I would say, follow your heart. Like if that's what you think you're interested in, then I think I would follow that and do that because it's extremely valuable. So Eitan writes, how are you able to balance having a family and working in the medical field? Good question. I have a family. I have, 2 sons, and they're now like teenagers, 14 and 17 years old. It's challenging. And I think, I've been really busy with the research and the clinical work, and then having a family as well. I'm busy a lot of the time. I don't have much time for like, Netflix or whatever. But it's a good busy. I mean, it's wonderful to raise a family and it's wonderful to have this career. But I think, each person needs to find their own balance. And I think work-life balance is really important. I think there are ways now with a career in medicine to have like a reasonable life where you do have some protected time for family life. And some of that depends on the particular path you choose. I mean, there's some specialties within medicine that are extremely demanding and, there's lots of emergencies and you're in the hospital all the time and you're doing surgery, and that makes work-life balance harder. But there are some other medical specialties where the hours are pretty confined, even like 9 to 5-ish kind of hours where it really is more possible to achieve a greater balance. So Beatrice writes, was there any additional training you had to do for your psychotherapy work? Did your specialization in medical school cover that training? And did you know that you wanted to go into psychotherapy while choosing a specialization? Yeah, most of my psychotherapy training was in my psychiatry residency after medical school, not in medical school itself. Like in medical school, we had a rotation in psychiatry that was only like a month long, a core rotation in psychiatry. So we did a little bit of psychotherapy within that rotation, but a month is not very long to do psychotherapy. And we had some lectures from psychiatrists and therapists that were interesting, but really the vast majority of my psychotherapy training was in psychiatry residency. And some people, even beyond their residency, do additional training. Um, so, and did I know that I wanted to go into psychotherapy while choosing specialization? I think, yeah, when I chose psychiatry, I knew that psychotherapy was part of it. And I found that appealing because one nice thing about psychiatry or psychotherapy is that I feel like you do get to know your patients in a kind of a deeper way than you do in many other specialties where, you get to know them, but, you may be dealing more with their diabetes and their diabetes management and things like that. And you're not getting into the kind of deeper aspects of their thoughts or their relationships and things like that. And I just enjoyed that. I enjoyed getting to know my patients in a fuller way. Enzo asks, could you go into more depth about your decision between specializing in psychiatry versus neurology? Was there anything in particular that led to your choice to pursue psychiatry over neurology or any other specialization? Yeah, so what I did, because I was having this dilemma in medical school of psychiatry versus neurology, is I did, in addition to the core rotation in psychiatry, there was no core rotation in neurology. So what I did was I took an elective in neurology. I specifically did pediatric neurology at Boston Children's Hospital. And then I also did an additional elective in psychiatry. So part of the way I made that choice was just by having more clinical time in each specialty and getting a sense of like which one I liked more. And I mean, there were a number of factors that led me to choose psychiatry. One, again, was this thing that I just said before about really getting to know your patients in a deeper level. I felt like, interestingly, and it felt like in psychiatry, sometimes there was more that I could do for the patients. Like you could do psychotherapy, you could give medications, and sometimes patients really would get dramatically better with those treatments. In neurology, this is not always the case, but it felt like there were a lot of issues where there wasn't a lot you could do. Like there were neurodegenerative disorders or dementia or strokes where you could try to minimize the impact, but once someone had had a stroke, it didn't feel like there was an awful lot that you could do. So in some ways, it felt like neurology was more diagnosis, less treatment. And I liked the treatment aspect. So that was part of it. Aubrey writes, would you say that doing clinical work or research in the lab has felt more rewarding for you? Why? I'm trying to go through these questions pretty quickly because there's a lot of them left, and I know we only have like about 8 minutes left here. I would say that they've both been really rewarding in different ways, and I've enjoyed having the variety of both. I think, and also over the course of my career, which one I found more rewarding has changed over time. I think that there was a time when I was really, really excited about the basic research, and in some ways could spend 100% of my time doing that. I feel like at this point in my career, I would probably say the clinical work is getting more rewarding. So it's shifted over time for me. Ray writes, how do you see technological advances impacting your field in the future? I think it's going to impact psychiatry and all of medicine in major ways, but I think we're going to increasingly get a better understanding of genetic influences on psychiatric disorders and a more sophisticated understanding of what's going on in the brain in these disorders through brain imaging and other methods. And ultimately, I think we're going to develop a better understanding of biological subtypes of psychiatric disorders. Even if you take what I study, like autism is actually a very biologically heterogeneous group of disorders. And we're more and more going to be able to say, like, it's this type of autism influenced by this set of genes, and this is the best treatment for this type of autism, more so than we do now. So I think that's one of the big ways that technology will affect it. Francesca writes, do you also work through any treatments for the patients you diagnosed? If so, how is treatment differed between the older patients, such as 70-year-old, and the younger patients, if any? Yeah, I think I've partially answered this before, but yes, I do treatments for a subset of patients that I diagnose. And in terms of the age, I would say that the treatment for people on the spectrum, adults on the spectrum, varies more by the particular issues that patient has, the particular areas in which they need help, and maybe not quite so much by their age. I mean, sometimes by the time people are in their 70s or their 80s, they feel like, and that's pretty rare that I see patients that old, but they may say, I just want to know. I want to know if I have the diagnosis. At my age, I am who I am. I don't feel like I'm going to change a huge amount, but it's would help me in some ways to know. But if they are interested in working on some things, I think it's still possible, even in their 70s. So Avi writes, what was the process like towards building up the entire autism spectrum program at Penn? It was a gradual process over time. It's still a relatively small program, and there's not a lot of people working in it. It's actually mostly me doing the work. But part of the process was really defining, like, what are the specific services that I want to provide? What can be referred elsewhere, and what would be sort of like a unique service that I could provide that's not being provided elsewhere? And what's the format of it and things like that, and how do we let people know about it? So it was a process over time. It took a few years to really get the ball rolling, but I think it's going really well now. So Isabella writes, based on the research that you've done on both mouse models and diagnostic work with patients, what would you say that presentation of aggressive social behavior as a symptom of ASD is more affected by genetics or environment? I don't know that I completely understand that question, if you're talking more about autism in general or about aggressive symptoms in particular, but there are patients on the spectrum who do show sort of irritability or aggression sometimes. I don't think we understand the genetics versus environment very well of that particular symptom, but in general for autism, there's a large genetic component to susceptibility. So people have estimated the heritability, like the degree to which it's genetically influenced, at about, I would say, somewhere in the range of maybe 50 to 70% of the susceptibility is genetic, and the rest of it is non-genetic. And we're making a lot of progress in starting to identify what the genes are. There's many, many genes involved. I think we know less about what the environmental factors are, so there's a lot left to learn there. So Larissa, I see it's 3 minutes before 9. I'm willing to go a little past 9 if you guys want to, but I also am respectful of your time. Like, if you want to just, we've got like at least 20 more questions that I haven't answered. So I'm sure we can't do that in 3 minutes, but what do you think, Larissa?
Yeah, I mean, I appreciate you willing to stay after. I feel like maybe if we could do like 5 more questions and then call it whenever that is, if everyone's okay with that. Because I know 20, that's also like, I don't want to make you like stay here for a while. So maybe we could do 5 more questions and then.
Yeah, that sounds good.
Okay.
Yeah. Okay. So Isabella writes, based on the research that I think I addressed that already. Janai writes, going off of someone else's question, how did you get to start your lab here? Did you have to collaborate with other researchers, apply for specific grants with a lot of publications in the field, et cetera? Yeah, so when you get recruited to start a lab, often the university gives you some startup funds, which I did get. And then I also came with something called a Burroughs Wellcome Fund Career Award, which I had applied for as a postdoc, which gave me some money for my postdoc and some money for my early faculty. So it was nice. I came with some money to buy lab equipment and get things started and hire someone. But pretty quickly, I did have to apply for grants. And definitely collaboration has been a big thing. Like I've collaborated all along. I think the way, science is now, you can't be an expert in everything, and science tends to be very collaborative, and Penn actually is a very collaborative environment. So it's nice. That's actually one of the things I really enjoy about science is the collaboration. So Alania writes, going off the question posed about whether there being a particular sect that often goes undiagnosed, have you noticed any trends when it comes to race, ethnicity? Yeah, I think that my sense based on research literature and even what I've also seen is that there tends to be racial disparities in the sense that I think more people from racial minorities go undiagnosed than, white people, basically. So I think the field and society has a lot to address here in terms of getting proper diagnoses to underserved, populations and minority groups. Michael Castillo writes, is there anything you wish you had done differently or could change about your journey in medicine and clinical research? Knowing what you know now, what advice would you give to someone who is interested in pursuing a similar path? I don't know that I would have changed anything. Like, I don't have really strong regrets about what I did. I mean, one thing that I am glad that I did was I picked something based on what I thought I would really like. Like, so for example, like going into psychiatry, I think this is changing now, but back when I was in medical school, there were some within medicine who felt like psychiatry was not like quote unquote real medicine. You know what I mean? It wasn't like being a surgeon or something like that. And so in some ways, in certain circles in medicine, psychiatry might be considered less prestigious, whereas like being a neurosurgeon or something like that might be considered more prestigious. But or I even met other doctors who were like, oh, I went into this specialty and I thought of psychiatry, but I just didn't have the guts to do it. Like, I don't know, like they felt like they wouldn't be considered as cool or something if they were in psychiatry. So I am really happy that I just went with my heart with that and did what I was really interested in. And one piece of advice I give to students is try not to worry so much about what other people are going to think of you if you do this career or that career or this specialty or that specialty. Go with more like what you really find interesting in and of yourself, because that's what's going to sustain you. I think some people have the fantasy, like if I become a neurosurgeon, my aunt will think that's so cool and they'll just be really impressed. And maybe your aunt will be, but that's not enough to really sustain you for your whole career, because then your aunt is going to go back to her life and get involved in her things. And it's not going to last for 60, 50 years that she's going to be impressed. And so what's going to sustain you is that you picked something that you really, really felt passionate about and that you really liked. Beatrice writes, do you think your exposure to more humanities-based subjects has helped you in your path in medicine? I think so. Yeah, I think that having majored in history of science has put things in perspective in a really nice way in terms of, doing science, but also even in psychiatry, knowing that what we understand now is not set in stone and it's going to continue to evolve. And, it's helped me to, in some ways, maybe be more empathic to the human experience, like having done some work in humanities. And yeah, I don't regret that at all. Bouncing off the question above, what suggestions do you have to make the most out of your pre-med experience in college? Were there any non-STEM related courses that you took that you find really help with your work today? I mean, I think really getting good at writing and expressing yourself in writing and speaking and just thinking critically and analytically is going to serve you well, no matter what you do. So I think that's a really good investment. So I think if you want to take non-STEM courses, I would encourage you to do it. If you have areas of interest, like I still remember an art history course that I took in Rembrandt to this day. Like I loved it. It stayed with me. Or a course in like philosophy and film that I took that I still really value highly many, many years later. So I would definitely encourage you to do that. And I would encourage you to balance, working hard and the stress of pre-med stuff with really taking some time to enjoy life and de-stress and realize, whether you go to this medical school or that medical school, it's not the end of the world. Like, you're going to have a good career. You guys are Penn students. I'm sure you're all really bright. And so take some time to enjoy your life now too. Okay, two more questions here and then I guess we'll call it. How big of an influence would you say the environment has in increasing the risk of developing ASD combined with genetics? I think the environment clearly has a substantial impact. It's not all genetic. It may be up to like halfway environmental. And so I think we need a lot of research and better understanding what that is. There's a whole thing about rising rates of diagnosis in autism. And I think for sure some of that is just a broader conception of what autism is. So a lot of people we diagnose today that would not have been diagnosed 30 years ago, because we had a much narrower conception of what autism was 30 years ago. But even accounting for that, there's maybe some evidence that there are some environmental things going on that are contributing to rising rates of autism. So I think we need to understand that better. And last question, if we are more interested in your work, research, or the autism spectrum department as a whole, do you have any contact info you could drop us in the chat? Sure. I would say, I could put it in the chat. Check me out online, just Google me and you'll find my lab. You can email me if you have questions. Another thing that I didn't mention is that I see that Bryn is here and she knows about this, but I recently wrote a book that is partially about autism, but it's more generally for the general public about like social connection, social communication. Here, I'll show you. It's a little plug for my book that I actually co-wrote with a Penn undergraduate, Ashley Palathra, who then worked in my lab, and now she's a PhD student in clinical psychology, but it's called Missing Each Other, How to Cultivate Meaningful Connection. So, and I'm really kind of into this topic. So if you're curious about that, we have a website, missingeachother.com. So if you just go to missingeachother.com, you'll see our website about our book. You can check it out there. So yeah, any of those things, and feel free to get in touch. Why don't I put my email address in the chat? It's pretty easy to find if you Google me, but so there's my email address. Let me make sure I got it right. ebrodkin@pennmedicine.upenn.edu. I'll put in, there's the book website. And we're also like, we have blogs now on Psychology Today and Medium, but you'll see all that on the book website. And let me quickly get my lab website and I'll put it in here. Shoot, that's the wrong one. Hold on one sec. Here we go. I think this one's right. Yeah. And one other thing that you guys might be interested in is we have a large autism genetics project that's involves a collaboration between my lab and a number of labs in the genetics department at Penn Medical School. So I'll put that website in the chat too. Oh boy, hold on one second here. I'm trying to get like, here we go. Okay, yeah, that's pretty good. So that's my, I put in my email address, my book website, my lab website, and the ASPE website, or this is the Autism Genetics Program website. And we're also doing another thing that some of you guys might be interested in. We don't have a website for this, but we're doing a treatment study for adults on the autism spectrum where it's like a cognitive behavioral treatment program to help them with social functioning. And we have a whole bunch of Penn undergraduates who are helping with that, but we may have like an opening on that project. So yeah, so, if not this academic year, maybe next academic year, we'll have more openings, but feel free to get in touch if you're interested. I would love to connect.
Awesome. Thank you so much for also staying past 9. We really appreciate having you. That was a great discussion.
Yeah, my pleasure. It's been really fun. Hold on one second. Someone sent me a direct message. Maybe since I think we have to wrap it up, anyone who direct messaged me, just shoot me an email and I'll get back to you that way. And that's maybe a better way to do that.
Yeah, and also we can like send out like a little info thing after this event to the members and provide your email in there as well if anyone has questions. So
yeah,
yeah,
sure thing. I mean, I would just say, are a lot of you guys are pre-med? Is that correct? Or yeah, I mean, there's a lot of negativity about medicine, and people say, well, medicine isn't what it once was. It's terrible. I mean, I still think medicine is a great profession, and I also really love to meet like college students and medical students, like young people who are interested. I think you guys are the future. You're the hope for our field, and we need bright people like you in the field. So I would encourage you, and there's lots of different career paths you can take within medicine. So I would say if you feel like you want to do it, then go for it.
awesome. Thank you so much.
All right, sure thing. Have a great night, you guys.
Thank you. You as well. Bye,
All right, take care.
everyone.
Bye.